Welcome to the deep dive.
Great to be here.
So today we're tackling a pretty complex subject, hypersexuality.
Yeah, definitely one that raises a lot of questions.
We're going to explore, what people mean by it, the whole debate around it being a medical condition.
And just the different ways it's been looked at over time.
Exactly. And for this, we're drawing on a really thorough overview, hypersexuality.pdf.
That's the one. It pulls together a lot of different research, medical, psychological. It's quite comprehensive.
Good stuff. So our mission really is to unpack all that complexity for you listening.
Try and clarify the different viewpoints, maybe some of the factors involved.
Right. And importantly, we want to do this without, pathologizing normal sexuality.
And without getting bogged down in the sort of politically charged bits.
Definitely steering clear, taking sides there. Okay, so let's dive in. What's really at the core of this idea, hypersexuality?
Well, fundamentally, it's been proposed as a medical condition.
Oh.
The idea is it involves unwanted or maybe excessive sexual arousal,
Leading to.
leading to distress, or it messes with your life somehow. Obsessing about sex, acting on urges in ways that cause problems.
But it's controversial.
Yeah.
Whether it's a real diagnosis.
Hugely. Yeah, there's still a lot of debate about whether it's a distinct clinical thing on its own.
And this isn't exactly a new concept, is it? The overview mentioned some older terms.
Oh, yeah, absolutely. Historically, you had different labels, and they're quite telling.
Like what?
Well, for women, the classic one is nymphomania.
Right.
And for men, satyriasis. There was even andromania for heterosexual women seen as overly interested in men.
Wow. Sounds pretty judgmental.
Very much so. They were loaded terms, reflecting historical anxieties, especially about female sexuality. Clinically obsolete now, of course, but they show how thinking has changed.
Okay, so the language has definitely shifted. Now, the source also talks about it being primary or secondary. What's that distinction about?
Yeah, that's really important. So primary means it's considered the main problem itself.
Just the hypersexuality on its own?
Kind of, yeah. Whereas secondary means it looks like a symptom, like it's popping up because of some other condition.
Okay, that makes sense. So seeing hypersexual behavior might be a clue.
Exactly. It could point towards something else going on underneath.
So what kind of underlying conditions are we talking about?
Well, the sources list quite a few. Some neurological things like Kluver-Bucy syndrome.
Which involves brain damage, right? Temporal lobes.
That's the one. Also, bipolar disorder is a big one. The mood swings can really impact sex drive.
Up and down?
Yeah, significantly. Then you've got brain injuries, dementia. Those can sometimes show up with hypersexual symptoms.
And even medications.
Especially certain ones that mess with dopamine levels. Think some Parkinson's drugs, for instance.
Interesting.
And the overview also flags damage to the frontal lobe from injury, stroke, even historically lobotomies as being potentially linked. Really highlights the brain's role in managing our behavior.
It really does. Such a wide range of potential factors. So beyond primary versus secondary, it seems like clinicians don't all see these behaviors the same way either.
No, definitely not. There's no single unified clinical viewpoint.
So what are the main perspectives?
Well, some frame it within the world of obsessive compulsive disorder, maybe on the OCD spectrum.
Okay, like a compulsion.
Kind of, yeah. Others lean towards an addiction model, compulsive sexual activity despite negative outcomes.
Like other addictions.
Similar framework, yes. And then others classify it more as an impulse control disorder, difficulty managing the urges.
Right. And then there's that other view mentioned,
Mhm.
the one that sort of challenges the whole idea.
Yeah, that's a really critical perspective. Some researchers basically ask, is this actually a pathology at all?
Or is it just society not liking certain behaviors?
Exactly. They suggest that maybe what we're labeling as a disorder is just cultural disapproval of sex that falls outside the norm.
That really makes you think, doesn't it?
Yeah.
Where's that line between a medical issue and just being different?
It's a fundamental question in this field.
And all this disagreement probably contributes to the huge variety of terms used. The overview mentions that.
Oh, absolutely. It's a direct consequence. No agreed upon definition or cause means. Well, everyone comes up with their own labels.
And they get used interchangeably sometimes.
Sometimes, yeah. Or sometimes a specific term reflects a particular theory or focuses on a certain behavior.
Can you give us some examples? It sounds like a bit of a mess.
It can be. You see things like compulsive masturbation, compulsive sexual behavior, cybersex addiction.
Netflix addiction.
Bet erotomania, that's the delusion of being loved by someone.
Okay.
Simpler ones like excessive sexual drive, but also hyperphilia, hypersexual disorder, problematic hypersexuality, sexual addiction, sexual compulsivity,
Wow.
sexual dependency, sexual impulsivity,
Mhm.
even linking it to paraphilia sometimes if there are atypical interests causing distress.
That's a long list. It really drives home the lack of standardization.
It really does.
And like you said, this must make it incredibly hard to figure out how common hypersexuality actually is.
Absolutely. The source is clear on that. No consensus on definition or measurement equals, well, shaky prevalence data.
But are there any ballpark estimates?
The overview suggests a range, maybe somewhere between 2% and 6% of the population. But again, that depends heavily on how you define it in the first place.
And any patterns? Like, is it seen more in certain groups?
There's some suggestion, yeah. Potentially higher rates observed in men, also in people with a history of trauma.
Okay.
And it's also noted as being more prevalent among individuals who have committed sexual offenses. But these are just broad trends, need more solid research there.
Right. Okay, let's dig into the causes a bit more. Sounds like there's no simple answer there either.
No definitive consensus, that's for sure. The overview touches on a whole spectrum of possibilities.
Like,
Well, in dementia, for example, it might be linked to actual biochemical or physiological changes in the brain leading to sort of disinhibition, less impulse control.
okay.
And it also points out that it's not just biology. Our psychological needs for intimacy, connection, they complicate the picture beyond just raw libido.
And you mentioned brain links earlier, the orbitofrontal cortex.
Exactly. Damage there is linked to problems with decision-making, social appropriateness. And that can include increased aggression or socially inappropriate sexual behavior, sometimes hypersexuality.
And temporal lobe surgery, too.
Unilateral temporal lobotomy, yeah, has been associated in some cases. Then there are other biological angles, hormonal shifts, like premenstrual changes or exposure to certain hormones during development.
What about testosterone? That's always linked to sex drive.
It is, but the research seems to suggest it's necessary but not sufficient.
Okay.
Meaning you need some testosterone for sex drive, but just having high levels doesn't automatically mean hypersexuality. Studies using drugs that lower testosterone show this complexity. It's part of the picture, but not the whole story.
Got it. And in dementia, other factors, too, like loneliness.
Yeah, the overview suggests things like a lack of physical closeness or even just forgetfulness about social rules or recent interactions could play a part.
And dopamine came up again, the reward chemical.
Specifically, the dopaminergic mesolimbic pathway. Think of it as the brain's reward highway.
Okay.
If that pathway becomes overactive, maybe naturally, like during mania, or due to drugs that boost dopamine, it's linked to impulsive behaviors. And sometimes that includes hypersexuality.
And the stress system,
Yeah.
HPA axis.
Yeah, dysregulation in the body's stress response system, the HPA axis, has also been associated with hypersexual disorder in some research.
Wow. It really is a complex web, biological, psychological, neurological.
Absolutely. And different groups emphasize different parts, like the American Association for Sex Addiction Therapy.
What does that take?
They definitely acknowledge biology, but they also really focus on psychological factors, mood, motivation, thinking patterns.
And other things.
Yeah, they bring in things like a person's sense of spiritual control, underlying mood disorders, history of sexual trauma, and even something called intimacy anorexia.
Intimacy, anorexia.
Yeah, basically avoiding emotional closeness in relationships. They see all these as potential contributing factors to what they call sex addiction. It's a very holistic view.
Okay. Now, we touched on this, but let's explore more how hypersexuality can show up as a symptom of other conditions. Borderline personality disorder, for example.
Right. BPD is a key one. Impulsivity is a hallmark of BPD, and that can definitely manifest sexually.
How so?
Things like intense sexuality, maybe seductiveness, sexual promiscuity, obsessive thoughts about sex. These are relatively common symptoms in BPD for both men and women, sometimes even more atypical sexual interests.
And mood disorders. You mentioned bipolar earlier.
Definitely. In bipolar disorder, the swings in sex drive can be dramatic and directly linked to the mood episodes.
So higher drive during mania or hypomania?
Exactly. The DSM itself lists hyposexuality as a potential symptom of manic or hypomanic episodes in bipolar disorder and also in schizoaffective disorder. It fits with the increased energy and lowered inhibitions.
Any other conditions?
Pick's disease is mentioned. That's a type of dementia affecting the frontal and temporal lobes, often leading to socially inappropriate behaviors, which can include hypersexuality.
And the list of neurological links seems quite broad. odd.
It really is. Alzheimer's disease studies show a percentage of patients exhibit sexually inappropriate behavior. Also, conditions like autism, brain injuries generally, Kluver-Bucy, Klein-Levin syndrome, epilepsy, other neurodegenerative diseases.
And we mentioned Parkinson's meds and recreational drugs, too.
Right, like methamphetamine, it's a wide net of potential neurological and substance-related influences.
And the source noted a link between how severe dementia is and the likelihood of these behaviors.
Yes, a positive correlation. As dementia progresses, the chances can increase, and the reasons why it happens in dementia are varied. Could be the disinhibition from the brain changes themselves, misreading social cues, maybe understimulation leading to seeking sensation inappropriately.
Or just old habits persisting.
Exactly. Persistence of learned sexual behavior even as other thinking skills decline. Plus, medication side effects, as we said.
And maybe that underlying need for closeness.
That too. A psychological need for intimacy that gets expressed inappropriately or just forgetting social boundaries.
It's complex. Could it even be a coping mechanism sometimes?
That's been theorized, yeah. As self-esteem and cognitive function decline in progressive illnesses, maybe increased sexuality becomes an unconscious way to compensate. Still needs more research, though.
And there's overlap with sexual addiction concepts here, too.
The source notes symptom overlap, like intimacy difficulties, depression, bipolar links, and emphasizes the real impact hypersexuality can have on someone's social life, their job, if these issues are significant.
Okay, let's shift to classification. How do the diagnostic manuals actually handle this? It sounds contentious.
Very contentious. The term sexual addiction, for instance, really struggled to get formal recognition.
The DSM, the American Manual.
Right. A proposal to add it back in 2010 didn't get enough support from the American Psychiatric Association.
So it's not in there as a distinct diagnosis.
Not as sexual addiction, no. The current DSM-5-TR has a category called sexual disorder not otherwise specified.
What is that used for?
It can cover situations where someone is really distressed by a pattern of repeated sexual relationships where other people are treated like objects, basically, but it stops short of defining a specific addiction.
Okay. What about the international classification, the ICD?
The older ICD-10 did have categories like excessive sexual drive, using those old terms, satiriosis and nymphomania,
Right.
and also excessive masturbation. But interestingly, even back in the late 80s, some researchers were questioning the whole concept.
Saying it was just labeling.
Pretty much. Levine and Troyden argued that calling urges extreme just stigmatizes people outside the norm, and maybe the idea of sexual compulsivity itself was flawed.
But the ICD has been updated since then.
Yes, and this is a really significant change. In 2018, the ICD-11 introduced a new diagnosis, Compulsive Sexual Behavior Disorder.
Okay, what does that entail?
It's defined as a persistent pattern of failing to control intense, repetitive sexual impulses or urges, leading to repetitive sexual behavior despite negative consequences or distress.
So the ICD does now classify it as a mental health condition.
Yes, that persistent lack of control is framed as a mental health condition in the ICD-11. It marks a notable shift internationally.
Interesting. So DSM is cautious. ICD-11 has this compulsive behavior disorder. This must affect how we think about the risks involved.
Definitely. Regardless of the label, the source points out some serious potential risks.
Such as?
Higher risk of getting STIs, one stat cited suggests over a quarter of affected individuals contract one.
Wow.
Also, a risk of committing sexual abuse and major damage to relationships. Another figure mentions nearly 23% of relationships ending.
And it often doesn't exist in isolation.
Right.
Other issues.
That's a key point. People experiencing hypersexuality seem more likely to have other addictive behaviors too.
Like what?
Co-occurring issues are common. Eating disorders, compulsive spending, substance problems, gambling addiction. It suggests maybe a broader issue with impulse control for some.
Given all this complexity and the different potential underlying issues, how do clinicians even begin to assess and treat this?
Yeah, it requires a really careful, individualized approach because people seeking help are such a diverse group.
So starting with a thorough assessment.
Absolutely. A comprehensive clinical interview is key. Getting the history of the problem, but also broader psychological, sexual, psychiatric history, substance use, medical background, everything.
And understanding any other conditions they have.
Crucial. Need to know about co-occurring disorders, ongoing treatments. Sometimes getting input from a partner or family can add important perspective too.
Are there specific assessment tools?
Yeah.
Questionnaires?
Yes, quite a few can help supplement the interview. Things like the Sexual Inhibition Sexual Excitation Scale, Intensity of Sexual Desire Scale, Compulsive Sexual Behavior Inventory, Sexual Compulsivity Scale, the Sexual Addiction Screening Test, various options.
And maybe more general psych tests?
Sometimes. Clinicians might use things like the Clinical Global Impression Scale, timeline followback to map behaviors, maybe the MPI-2 or Million Inventories for broader personality assessment.
Okay, and then treatment. What's the goal?
Usually the main goal is helping the person gain control over the urges or stop acting on them in harmful ways.
And how is that done?
Often, a multifaceted approach works best. Therapy plans need to be tailored considering their history, symptoms, other conditions.
What kinds of therapy?
Common methods include cognitive behavioral therapy, CBT, relapse prevention, psychodynamic therapy, and sometimes medications, psychopharmacological treatment.
Different formats, too. Individual, group.
Yes, treatment can happen one-on-one, with a couple, or in a group setting.
And that addiction concept that seems influential in treatment, too.
Very much so. That idea really took root in the 1970s, partly from people in AA noticing parallels with their own compulsive behaviors.
Leading to specific support groups.
Exactly. You got the development of 12-step groups like Sex Addicts Anonymous, Sexaholics Anonymous, Sex and Love Addicts Anonymous, Sexual Compulsives Anonymous, providing peer support based on that model.
And medication is sometimes used to reduce drive?
Some individuals might use medications considered aphrodisiacs, yes, to help manage intense urges. Alongside therapy, support groups, counseling, lots of potential components.
Finally, the overview loops back to the history of the words themselves. It's fascinating how the language changed.
It really is. The term hypersexuality itself goes back to the late 1800s sexologists like Krafft-Ebing.
In Psychopathia Sexualis.
That's the one. Though, interestingly, his initial use of hypersexuality was actually for what we now call premature ejaculation.
Huh. And those older gendered terms we mentioned.
Right. Satiromaniac, Dondronous for men, nymphomaniac, clitoromaniac for women. Very dated.
Were there gender-neutral ones, too?
Yes. Things like hypersexualist, sexaholic, erotomaniac, hyperphiliac, and even more archaic ones like Messalina complex, hyperlibido, furor uterus.
Pure uterus. Rage of the womb.
Essentially, yeah, shows the historical biases. Even literature picked up on it. The Earl of Rochester wrote about themes related to hypersexuality way back when.
It really shows how these behaviors have been noticed and debated for centuries under different names.
Absolutely. The language reflects the understanding or misunderstanding of the time.
Well, this has certainly been a deep dive. We've really unpacked the sheer complexity and the controversies around hypersexuality.
Yeah, it's clear there's no single, simple definition, and so many potential factors involved: biological, psychological, social, cultural.
All playing a role in how we understand these really intense urges and behaviors. Considering all those angles feels crucial.
What really strikes me is how our understanding is still evolving, moving from those old judgmental terms towards something like compulsive sexual behavior disorder in the ICD-11.
It shows progress, right? Even if the debates are ongoing.
Exactly. It's a field in motion.
So, maybe a final thought for you listening. Given this evolution, how we classify these things, how we talk about them, how might societal norms and medical understanding continue to shift?
And what could that mean for individuals, for relationships down the line?
Definitely something to chew on.
Right.
Thanks for joining us on this deep dive.